Hello everyone, my name's Helen Baxter. I'm the coordinator for the ITHAcA HIT, and we've been talking about what it would look like, what success would look like for ITHAcA. And so that's really going to be the theme of today. And I've used a sort of a holiday sunshine theme just to combat the weather going on out there. Where's my clicker? Ah, right. Okay, so this is ITHAcA. So at the top, we've got Sarah Purdy from Bristol University, Peter Goyder from Bristol Clinical Commissioning Group. So we're actually led by Sarah and Peter, so we've got academic and a commissioning lead. Helen from Devon Partnership, Mental Health. Peter, who's got links with so many organisations, so Avon Primary Care Research Collaborative, the Clark, the Academic Health Science Network. Jonathan Benger, NHS England, UE and UHB. That's a nice picture of Tim Y, who wasn't available for a photograph, so he was on holiday in Mallorca at the time, so that felt appropriate. And James Calvert from North Bristol Trust. And so this is the ITHAcA team and we are working very much to look at avoidable admission, to understand more about avoidable admissions, but particularly within the urgent care system. And this is ITHAcA in Greece. So this is a real place. And this was said to be, from the Greek histories, the home that Odysseus was trying to get to. So Odysseus was a Greek hero who was very clever and savvy, but it also took him a really long time to get where he wanted to go, and we really hope it's not going to take us that long. So this is our focus, the urgent care system. As you can see, the poor patient's looking a little bit overwhelmed and confused there, and things don't seem to be working properly. And so we're very much trying to understand what we can do to help that. And this is our work stream. So we are focused on avoidable admissions, but we also have additional work streams in using data to inform commissioning and managing risk. Now, we're very much a research-orientated HIT, but we do a lot of knowledge mobilisation, and that ensures that the research we're producing is really getting out there and being used. So this is the knowledge mobilisation cycle. So we produce the research that we pass on to the CCGs and the providers, that's then implemented. And this leads to the unanswered questions that then inform the next loss of research. And we've been working towards this circle, this virtuous circle, as we call it. And it's quite a long road. There's quite a lot going on in the urgent care system and problems with avoidable admissions. But we've had a lot of friends along the way. And these are our friends. And these are some of the friends we've had who've given us funding and supported us. And these are some of the friends who have been working with us on the project. So we're working across quite a lot of organisations. And focusing firstly on our workstream avoidable admissions, we've got a project in each of our core areas which have been identified by the research. So we're looking at care bundles within secondary care. We're working with the Dementia HIT to try and understand causes and reasons for admission for dementia patients. And we're also mapping the services for children's asthma. And these are the 3 hits that we're collaborating with on our projects. So we've got Rubicon, CHIPIC that you heard about earlier, and dementia you've just heard about. And the project we're working on with the CHIPIC hit that Julie was describing is very much around why people are attending A&E. So that's why we've collaborated with them and the Red Cross to look at this. We're also working with the Clark, the Department of Physics at the university, and the Rubicon hit to try and understand whether we can develop a device that's going to help reduce the rate of antibiotic prescribing and consequently reduce admissions for people with UTIs. And we're working with the 2 commissioning groups, Bristol and South Gloucestershire, to develop a tool to evaluate avoidable admission services. We're also, one of our challenges has been in the use of data. It's been very difficult to get hold of data, but we are working to do an evaluation of the complex assessment unit in Southmead, and we're working with the clinicians there to try and understand how they're influencing length of stay. And we're currently talking to an organisation, the Centre for Sustainable Energy, who very much look at cold homes and how that can affect health issues. And we want to understand the influence of that on admissions. And our third work stream is managing risk. So we've just finished a project looking at the use of abnormal test results in out-of-hours care. And that's been very successful, and the commissioners are currently talking about how that's going to be implemented. We're trying to understand reasons behind why discharge from secondary care might be problematic with elderly patients. And we're working with the team up in Southmead to try and understand more about their clinical decision making. And we're working with both South Gloucestershire and Bristol CCG to understand how useful a brief, a holistic assessment would be to GPs when treating their elderly patients, and if we can reduce admission rates through that. And a new area for us now is to actually understand more about alternatives to acute care, whether we can actually keep people out of hospital entirely. So the bottle of vodka was just to keep everyone awake. But what we're really trying to understand is, can you do absolute admission avoidance? And we've just finished a systematic review that suggests that there is evidence that people can be cared successfully at home. And this work is in partnership with UE, Bristol University and the Trust and Bristol CCG. And we've got some new friends coming on board, hopefully now. So we're talking currently with Nokia, BT and EE, who are very interested in working in health services, to try and see if we can find some areas of interest for collaboration with them. And what we hope is that at some point we'll get to this, where it's all working really well, and the patients are happy and they understand the system. And then ITHAcA can have a nice rest.